Hello, hello. So welcome to an episode of the Practical 30 Live. Tonight, we're going to discuss the COVID-19 vaccine. Tonight's episode is titled Real Talk about the COVID-19 vaccine. And I will be joined by my friend and colleague, Dr. Stephaun Wallace. But before we get there, first, I just want to say Happy New Year to everyone. I'm excited because this is the first Practical 30 Live of the new year. So Happy New Year to everyone. I know there's a lot for us to be excited and optimistic about. So it's just a good time. So I'm looking forward to having this conversation. At the end of the year, things got really busy. For those who don't know, in my day job, I oversee 14 clinics, and our clinics have also been involved in doing COVID testing, and now we're involved in doing vaccinations. So things got really busy. So I'm excited to have the opportunity to have this conversation tonight to talk about something that is so important in changing the trajectory of this pandemic and getting us back to some sense of normalcy. So now I'm going to introduce my guest, Dr. Stephaun Wallace. So Dr. Stephaun Wallace is a research epidemiologist, public health and business consultant, and an internationally recognized public health social justice leader. He has more than 2 decades of global experience in public health and human resources and social justice efforts, and more than a decade of experience conducting public health research globally. He is the director of external relations for the Fred Hutch-based COVID-19 Prevention Trials Network and the HIV Vaccine Trials Network, a staff scientist in the Vaccine and Infectious Disease Division at Fred Hutch, a clinical assistant professor in the Department of Global Health at the University of Washington, and director of the Office of Community Engagement in the UW Fred Hutch Center for AIDS Research. Dr. Wallace, a U.S. Army veteran, has earned master's degrees in management and organizational leadership and a PhD in public health epidemiology. Dr. Wallace holds membership in and serves on the board of numerous regional, national, and international organizations. And last but certainly not least, Dr. Wallace is a legend in the house and ball community and chairman of the House of Blonde. Without further ado, Dr. Stephaun Wallace. Dr. Wallace.
Hello, hello.
How you doing tonight?
I am good. I'm here and I'm good. I'm with you, so everything is good.
Yeah, we're about to have a great time tonight. I agree with Project Wish. We love Dr. Wallace. I completely agree.
Oh, I love you all.
So, Dr. Wallace, I brought you on tonight for obvious reasons. Your CV, your bio, definitely talks about all the important things that we should be discussing tonight, which is where we are with this COVID-19 vaccine, and hopefully educating folks and getting them to a place where they'll consider the vaccine and take the vaccine.
Hopefully.
Hopefully.
That's the goal.
So I have a few questions to ask you, and then from there, we'll open it up to the audience. We'll do a Q&A so that we can answer folks' questions and hopefully dispel some myths along the way and get folks thinking about how they can get the vaccine and how they can talk to their friends and family about the importance of doing so as well.
Awesome. Okay, let's do it. I really like the background, by the way.
Thank you. So first, let's start with a quick overview of the current 2 vaccines that are currently being distributed in the United States.
Yeah, so the 2 vaccines under emergency use authorization have been developed in part by Moderna as well as Pfizer BioNTech, and these are, as I mentioned, they're under emergency use authorization. And what that basically means is that during a public health crisis, the FDA may authorize the use of a medication or an intervention while it's still under clinical trial if the risk and benefit analysis suggests that people would benefit greater by this medication being deployed as opposed to waiting. So this is an important consideration. And I guess one of the other things I would mention about this is that these vaccines are designed to, and how the clinical trials were designed for them is that they're designed to prevent or to look at preventing severe illness relating to COVID-19. So we are not sure yet whether or not the vaccines will prevent infection or transmission of the virus that causes COVID-19. So we're hoping to find that information out as soon as we can. And certainly we will update people when that information is released. But there is an imperative, as you probably know, based on the work that you do. The healthcare system in our country was already fragile prior to COVID-19. And as a result of COVID-19 and the rates that we continue to see, hospitals are at or near capacity. The rate of cases is certainly something to take note of, but I think also really important is the rate of hospitalizations and deaths that we're seeing. And so this is an opportunity, this is an intervention that has shown efficacy, 94 to 95%, to prevent people from getting seriously ill, which would put them in the hospital and may result in their death. So we have an opportunity, I think, to really consider how we might, utilize this at the individual level. And certainly, obviously there's a lot of work happening to ensure that this vaccine gets out to communities at the sort of population level. I will also add that for the Moderna vaccine, happy to say that one of my colleagues, Dr. Kizzmekia Corbett, who leads the scientific response for COVID-19 out of the Vaccine Research Center, NIH, a Black woman who is from the South, who who has been involved in this process. I think it's really important to note that a Black woman had a hand in developing this vaccine that's being tested, and that there are Black people and people of color all throughout different areas of this process of, whether we're talking about the conduct of clinical trials at our research sites, the design of the trials, or even reviewing the data, looking at, what's coming from these trials. The National Medical Association, one of our partners, developed a task force specifically to look at the data from the trials and to provide an independent review as in consideration for emergency use authorization. And the NMA, as many people may know, is the largest physician healthcare association in this country focused on Black healthcare physicians, Black healthcare workers. So there are lots of eyes watching this process. There are lots of people who are involved, and there are lots of resources that have been poured into this process to help it get to this place as quickly as it has.
Awesome. Thank you for that overview. And, I just wanted to comment on when you talked about the deaths. At this point, we're at over 400,000 deaths in this country alone, and so this virus is definitely taken a toll.
Absolutely. And we're projected to see, over 500,000 in the next few weeks based on, the way that the numbers are going currently. So it's, this is not something that we see changing without an intervention. And so besides practicing the measures that have been recommended by the CDC and health departments and our federal partners, the vaccine plays, I think, an important role in this process as well.
Totally agree. And, it reminds me so much of our work in HIV, just thinking about the toolbox that we need to be able to address this pandemic, right? So we need the vaccine, we need treatment, we need people to wear their mask and practice that social distancing in the same way that we need people to protect themselves, from STDs and HIV. So I see a lot of the similarities between the two.
Absolutely. And, for vaccines, vaccines have played a major and critical role in reducing the burden of disease in communities for a very long time. I mean, many of us don't even have an idea of the impact that smallpox and polio had in our communities because we have the benefit of people being vaccinated and not having to experience the impact of those particular diseases. And for many communities, they have been vaccinated. I know schools are requiring it on some level as well, measles, mumps, and rubella. And for a while, we were seeing, relatively low cases of these viruses in communities. And unfortunately, there were some communities who sort of scaled back their vaccination efforts, and we saw some blips.
Yeah, particularly in measles last year, and we saw some mumps cases last year as well here in LA.
Absolutely. And so this is what happens when we aren't diligent and vigilant in our public health response.
Yeah, I completely agree. So just a little bit about those two vaccines. So for those who are unaware, the two that have emergency use authorization, or we'll say EUA for short. So we have the Moderna vaccine, and we have the Pfizer and BioNTech vaccine. So that vaccine is a partnership between Pfizer Pharmaceuticals and BioNTech, which is a German company, right? And so if we start with the Moderna vaccine, for those who are unaware, actually both vaccines have 2 doses. The Moderna vaccine, you get 1 dose on, let's say, day 0 or day 1, and then 28 days later, you get that second dose. So day 0, day 28, you get 2 doses. And then after those 2 doses are done, at least based on the data that we saw, 2 weeks after day 28, so that's day 42, so this is almost a month and a half after, the person will have 95% protection against the virus. So that's Moderna. So then let's talk a little bit about Pfizer. So
I want to clarify just really quick that the protection is actually against illness and not the virus itself.
Okay. So against severe illness, 95% protection against severe illness. So then with the Pfizer vaccine, 2 doses, 1 dose day 0, 1 dose day 21, with 94.1% protection against severe illness. And both of those are extremely high efficacy. I think that's something that we should mention, how high that is, even in comparison to the flu vaccine. So when you think about the flu vaccine, the efficacy is anywhere between 40 and 60%. The flu virus mutates rapidly. So 40 to 60% versus 94.1% and 95%. So really amazing what the science is showing around protecting from severe illness with these vaccines.
Absolutely. And these trials were conducted independently. And in addition to that, there was a lot of effort being done and happening during the enrollment period of these trials to ensure that they enrolled diverse people, that these trials are representative of communities of color in particular. And so for the Moderna study, as an example, Black African-American persons represented about 10% of that study's population, and Hispanic, Latinx, or Latina persons represent about 20%, Asian communities about 5%, American Indian, Alaska Native communities about 1%. And in the Pfizer study, Black African-Americans represent about 9% of persons in the study. And Asian communities represent about 4%, American Indian, Alaska Native, a little bit less than 1%. And Hispanic and Latino communities represent about 28% of the Pfizer study. And these studies enrolled people of diverse ages, 18 to, I think, greater than 65. And we're looking at also people who have underlying health conditions. So people who presented with diabetes, higher body mass indexes, as well as other conditions, cardiac heart disease, chronic lung disease. So there were quite a few different kinds of groups of people in these studies. And I think that it's really important to communicate that as well.
I agree. So what I hear you saying is that for both of those studies, between 36 to 50% of the participants were people of color.
Absolutely. Absolutely. And that, those are large numbers. People of color are not generally represented in clinical trials to this degree. So there's a lot to acknowledge, in terms of the efforts that have been made to meaningfully engage communities as part of the design and implementation of the studies, as well as the work of enrolling diverse participants in the studies at the clinical trial level.
Completely agree. All right, Dr. Wallace. So what are some of the unknowns about the two vaccines thus far?
Yeah, I think the biggest unknown is, again, we don't know whether or not these vaccines prevent, infection, and they, prevent transmission. That is a huge sort of hurdle that we need to jump in terms of our awareness and our knowledge of this. And so we're working diligently on that, as well as designing and putting forward studies that are going to focus on persons who were not included in the phase 3 trials, and that includes persons who are pregnant, as well as youth and children. So those studies are forthcoming, and we'll be able to see that data soon, hopefully, as well.
Yeah, you bring up a great point when we think about the unknown of transmission even after you've been vaccinated, because the recommendation is currently that even after being vaccinated, that you should still be wearing your mask and practicing that social or physical distancing. Because what we don't know is, is the virus colonizing the nose? Is it, colonizing the mouth, if you will, and able to then be spread by someone who is protected from severe illness by the vaccine and potentially protected from being infected with the vaccine, but I'm sorry, with the virus, but still is carrying that virus on their body.
Absolutely. So, I mean, people could get the vaccine and could theoretically still potentially, acquire the virus and even potentially transmit it onwardly to other people. So, these are things that we need to continue to wrestle with and to understand. And again, those analyses are ongoing. Some recent reports came out, even because I know the concern about the viral variants has been, a topic of conversation for many people. And I guess I just want to offer that viruses have a goal. Their goal is to occupy our host cells and replicate. That is literally their function. And so I think the challenge is that when you have too much replication, the replication isn't perfect. And so we see these sort of slight changes in the virus as it begins to multiply or replicate. And these changes create other sort of mutations. But what we've learned is that from the Pfizer and from the Moderna vaccines is that they seem to be able to work well against the viral variants that have been identified in a few other countries. So,
yeah, I think it's important to note that we expected that this virus, like other viruses, is smart and is going to mutate. And so we expected that we would see variants. I think some of the promising data, as you mentioned, is that we're not seeing that these variants are able to penetrate, if you will, through the vaccine, at least at this point. We don't know what's coming in the future, right? As more variants will undoubtedly present, but at this point, that's really positive. I also saw Dr. Rochelle Walensky of CDC talk about how she feels that we have some cushion because of how high the efficacy is right now as well. So I think that also speaks to the strength of these vaccines and the development and the efficacy of the vaccines.
Great points.
All right. So who should absolutely not get the vaccine?
Who should absolutely not get it? I'm not sure if anyone should absolutely not get the vaccine. I think that there's some considerations.
Okay.
So people who have a history of severe anaphylaxis, that's an allergic reaction. And I don't mean when, you have a reaction and something mild, or something happens and, you pop a pill and you're good. Severe, like you're taking an EpiPen, and injecting it in yourself, right? or you're potentially going to the hospital if you eat something or do something that you have a reaction to. So people who have a severe reactions and have a history of this are encouraged to consider whether to choose one of the two vaccines that are currently under EUA, or to consider delaying until other vaccines come forward that would not have this sort of reaction. And then for those who choose to accept one of the two vaccines that are currently under EUA, the consideration is one, that they notify the vaccine center that they're going to get vaccinated. Obviously having a conversation with your primary healthcare provider, and then ensuring that the vaccine center has you waiting for about 30 minutes as opposed to the typical 15 minutes, just to make sure that people can observe you in case something does happen. And what I understand is happening at the sites that are doing the vaccinations, if persons begin to show any symptoms of anaphylaxis, they're immediately administered the EpiPen, and 911 is called so that they can get a medical evaluation, ensure that there are no issues there. So.
Yes, I worked one of our vaccination pods on Monday, and so I had a few patients that I had to administer Epi and also Benadryl to on site. So definitely, having those things available. Of course, this vaccine is being given in a healthcare setting, even if it's in a drive-through setting. There are, physicians, nurses, other healthcare personnel on site. I completely agree that 30 minutes. The other thing I'll mention is that if a person knows they have a history of an allergic reaction to PEG or polyethylene glycol, which we see actually in a lot of things, including dermal fillers. We also, if you're at the age where you've had a colonoscopy, PEG is also kind of used to prep you before you go for a colonoscopy as well. So if a person has an allergy to PEG, we see that as an absolute contraindication, at least to the two vaccines now. So I think that's important. And then if they have an allergy to polysorbate as well, to just wait until we get additional vaccines to then determine if that would be the best vaccine for you.
Absolutely. And again, always speak to your healthcare provider and make sure you're having those conversations.
Mm-hmm. So before I move on, one other thing I wanted to mention, because I think it's important for folks to know, is that those who are in the trials who received vaccine, you all are continuing to monitor them, right? To determine if there are any effects to that vaccine.
Yeah. So persons who are still, all the way back to the phase 1 studies, right?
Mm-hmm.
That
Mm-hmm.
looked at safety. These studies were just 100-person studies or so. Those persons are still in follow-up. Persons in the phase 2 trials that looked at safety as well as an indication of whether or not the vaccines would be effective, those persons are still in follow-up. And then, of course, the persons in the phase 3 trials are still in follow-up as well. So
I think that's important to note, because you are accumulating safety data from essentially day one, at this point.
Since March of last year, really. Since March of last year, we've been accumulating the safety data in people. So
Almost a year.
This is ongoing, and we will continue. These particularly the phase 3 trials are about 18 months to 2 years in length. So we'll have, we're going to continue to collect data, and also data from persons who are, being vaccinated currently through the VSafe program, through VEERS. And these are programs that are set up so that we can collect this data and continue to analyze it and look at trends, whether we're seeing any considerations that we need to be aware of to ensure we're always being mindful of safety.
Yep, I think that's important, that people know safety is top of mind. We're not trying to give a vaccine and then forget about it. If there's an adverse event, we want to know about it. We're tracking them, so that if necessary, we would stop giving that vaccine or take a pause, which, last week there was a pause taken for a batch of the vaccine. So, safety is top of mind for all of us that are doing this work.
Absolutely.
So I'm going to move us on to some myths because I think it's really important that we address those.
It is.
And some of them are kind of fun. So the first one is that COVID-19 is a man-made virus, maybe created in Wuhan and accidentally or intentionally released. What do you say to that, Dr. Wallace?
Yeah, this is absolutely not accurate. One of the things I think is really important is that many viruses have jumped species, and the way that we as people take over areas and move into and move into or colonize areas that have not been previously inhabited, and there's an opportunity for that to happen. We saw this with Ebola, we've seen this with other viruses. And when you factor in global warming, this is an experience that I think we will see going forward, if I'm being honest. So no, not man-made, and this is not some intentional biological weapon.
100% agree. All right. So did 5G cause COVID-19?
I'm trying to wrap my head around how radio signals might cause a virus. I remember when I heard this was probably March or April of last year. The short answer is 5G did not cause COVID-19. 5G also did not cause the virus that causes COVID-19. 5G is a radio frequency similar to the radio frequencies that are emitted from one's cell phones. And they're on the same wavelength as, other frequencies that you experience, whether it's TVs or microwaves. And so these waves do not cause viruses.
Nor do these waves adequately penetrate the skin to cause toxic changes to the cell. So I think that's also an important thing for us to mention to folks, because some of the 5G concerns is that that the radiation is causing toxicity to the cells. And so we've looked at 5G. We strongly believe, based on data, that 5G is safe on all fronts. And, I was also doing some additional reading about this and saw that this is definitely a narrative that could be pushed by some of the countries that we're in competition with to attempt to slow down the technology that we are developing in this country that can positively affect our economy. So having some of that disinformation pumped in from Russia and other countries to slow us down and to get people kind of on the wrong page.
Yeah, I appreciate you saying that, because, my sense is that there is an active effort outside of this country to propagate misinformation with people in this country to impact our society. And this idea of 5G being able to do this, to me, is completely aligned with that. And I also have to wonder, why is 5G so damn special? Why didn't 4G do this?
4G didn't do it, but 5G is definitely going to do it, right? It got faster. It's definitely going to go deeper, into the skin. Yeah, it's creating whole viruses at this point.
Yeah, I think that these are, there's something underneath this that I want to address, but I'll wait till you finish all of your questions for this myth section.
All right. Well, I have a few more. So the vaccine can give you COVID-19. Can the vaccine give you COVID-19?
Well, no. And there's two reasons why. One, because COVID-19 is actually the disease and not the virus. The virus is SARS-CoV-2, severe acute respiratory coronavirus 2, and this virus is the virus that causes COVID-19. So there is no live, weakened, dead versions of the virus being used in the vaccines.
What's being used in the vaccines? I can tell them if you want, or
So we're basically looking at the structure of the virus, right? And we're taking a piece of the structure called the spike protein, and we're copying this in a laboratory in order to create these vaccines. And for the mRNA vaccines, they don't even use that technology. That was the technology I mentioned for the other studies. But for Pfizer and for Moderna, they're actually using the script that creates these spike proteins, and that is the mRNA. And so it's being put inside of this sort of nanoparticle capsule, and added some sugars to help keep it moving and to help preserve its life, and some salts to ensure that when it's injected, it doesn't, disrupt your pH balance in your body and cause it to sort of attack the very thing that's being injected to protect you. And so then, the mRNA then goes into your cell just far enough to be able to do its work. It doesn't have the ability to penetrate the nucleus of our cells or interact with our DNA in our cells at all. So it simply enters the cell just far enough to be able to do this work. And it literally then sort of, the nanoparticle shell sort of disassembles and the mRNA gets to work. It's basically a script. It's sort of like, I know Dr. Corbett mentioned Snapchat as an analogy, but it's similar to it's similar to like a factory, essentially, like producing this spike protein. And after it's produced the spike protein, your cell pushes it out onto its surface. The mRNA disassembles within 24 to 48 hours. And so then you have this spike protein that's on the outside of your cell. That is what alerts your immune system. That is what teaches your immune system how to recognize that this thing should not be here. And so then that is really the function of vaccines, right? Is to teach our bodies how to fight off disease and infection. And so after the spike protein is pushed out to the exterior of this cell, your immune system goes into its work. Like, hey, this thing is here, is not supposed to be here. Let's get it. And so then it mounts a defense and again learns how to attack it. And the spike protein itself disassembles and goes away within, I think, 72 hours. So none of the components that you're injected with actually remain in your body.
That's a very, very important point. One thing that I wanted to mention, so when I think of the spike protein, which is on the outside of the virus, I think of that as a key, and I think of the receptor on our cell as a lock. And so that protein key unlocks the cell and then is able to get inside of the cell, right? Once it's inside of the cell, it's able to replicate in the cell. So the other thing I want to mention, because I think this is really important, the next myth is around can COVID-19 or can SARS-CoV-2 rather, can it affect the DNA? And it cannot affect the DNA because the DNA is in the nucleus. This mRNA does not come in contact with the nucleus, so this is not affecting your DNA and cannot affect your DNA.
Absolutely. Yeah. I said that a moment ago, but I think it should absolutely be mentioned and highlighted and restated as many times as possible.
Yeah, because we need folks who are on this call to share this or on this video and meeting and conversation to share this with others. It's, because I think that they'll have more of an impact on their friends and family than, say even reading it at times.
I think it's really important, Dr. Moore, and also because for this reason, I continue to hear healthcare workers. I saw a video of a nurse practitioner this morning who was talking about this topic, and I won't mention her name here, but Black woman who was talking about the messenger mRNA platform and specifically said multiple times in her video, meant to educate people about what was going on, and to sort of under the guise of sharing with them what other people aren't sharing with them, as if there's some conspiracy to hide information. But so
Which doesn't help.
Yeah, which doesn't help. So she said to people that the mRNA actually does interact with our DNA. And she said this multiple times, and that she's a nurse practitioner, and that she's a Black woman doing this. Like, this is another reason why, and I've said this before. Um, uh, you know, we need to share information that's accurate. We need to, go to sources that are credible. And everyone who is talking about this topic does not necessarily have the perspective, the authority to talk about it in a way that I think supports ensuring people get access to accurate information to make informed decisions. I've said in other public spaces, and I will say here, I am personally planning to get the vaccine. I am really concerned that people get accurate information to inform their decisional process. I'm not here to convince anybody to get a vaccine. That is a personal decision. You have to make a decision for yourself, for your health, and the health of your family. But we absolutely have a responsibility, particularly those of us who work in the medical field, healthcare, and research, to communicate accurate information.
I agree. To be well educated and then be able to, provide that accurate information and do our own reading and understanding to be able to clearly convey accurate and factual information. Totally agree. So the next myth, the vaccine contains a microchip with the mark of the beast. That the idea that the chip will allow the government and corporations to surveil people who get the vaccine.
Okay. Well, that is also not accurate. And I can probably do a whole TED talk about why this isn't accurate, but I will simply say that there is no microchip technology in the vaccines. The syringes that are being used would not even accommodate a microchip being placed into someone. Typically, when we talk about implanting things in people, the gauge of the needle needs to be a little bit larger than the gauges that are being used to administer vaccines. I can't say anything about a mark of the beast and, people surveilling people. We have, there are programs in this country that are responsible for surveilling people. I don't know that they need a microchip to do it. People, everywhere using cell phones and other technology that to me works just as well. Civilians can gain access to people's home cameras and, cell phone cameras. So, yeah.
Alexa and Siri are listening right now.
Absolutely.
So if we're worried about surveillance, it may be time to kind of turn off those devices that are listening,
And we invite the technology into our spaces, into our homes that has the ability to do this. So,
Agreed. Last myth, instead of taking the vaccine, we should all just get COVID-19 and build herd immunity.
I continue to be impressed by the way that herd immunity had been talked about last year incorrectly. One I will say is that everyone getting COVID-19 will not necessarily result in herd immunity. That's one. You're likely putting people more in danger and literally placing lives at risk by the even idea of that. The other thing I will say is that COVID-19 is not a disease that we have understood that people can only experience one time. And so just because a person experiences it doesn't mean that they cannot experience it again. I've seen anecdotally, people acquiring the disease multiple times.
Yep.
And so we will not get to herd immunity in that way. And I think, can I clarify? The idea of herd immunity does not happen from intentionally exposing people to a pathogen. It happens through vaccination.
Yep.
And it's the same concept that I was talking about earlier when I was talking about polio and smallpox, as well as measles, mumps, and rubella. We can see herd immunity when vaccination levels are so high that the virus has no ability to be transmuted or transmit through the communities or through our our families, our homes, our society. So we need to get to a place where there is little to no virus, and exposing people to COVID-19 or suggesting that people should get COVID-19 to do this is the complete wrong way to approach this.
Yep. And if we went down that road, we would lose hundreds of thousands of people would die. Those who are exposed, everyone who's exposed and infected with COVID-19 or with SARS-CoV-2 and getting COVID-19 will not survive, as we've seen. As I mentioned, over 400,000 people in this country have died from it. So I actually like to think of vaccines as the safe way to develop herd immunity, as you just mentioned, because we are exposing folks to a small particle that then allows their body to build that immunity that then will allow them to fight off the virus if they come in contact with it. So, herd immunity, no, it's not going to work. And so any of those COVID parties, I've heard about many COVID parties where people are exposing each other. Sure, you may have immunity for 90 days, but then you could still get reinfected again. So, okay, you want to be really sick and then possibly die, because we have seen some young people die as well, or then be reinfected later. Better to get the vaccine as soon as it's available to you.
There's another aspect of this I want to speak to briefly, and that is, as I mentioned before, our healthcare infrastructure was fragile. And certainly it's been challenged since. And so if we're talking about people intentionally exposing themselves to this virus and getting sick in order to manufacture some mystery or fairy tale herd immunity, what we're ultimately saying is that we want our healthcare system to collapse. And we want to be in a position where people are having to make decisions about who will live and who will die based on the availability of equipment that can save people's lives. So this is a dangerous line of thinking for a few different reasons.
Mm-hmm. I agree. I totally agree. So, Dr. Wallace, I could talk with you all day. We're gonna jump to some questions from the audience. Let's see. Scrolling through my questions here. Dr. Wallace said the vaccine protects against illness, but not infection. Does that mean that those who receive the vaccine can contract COVID-19, but just not get sick?
Well, what I'm suggesting is theoretically people could acquire the virus. COVID-19 is the disease. So you're not contracting COVID-19. You would be contracting the virus. Mm-hmm. But you could acquire the disease and you have a 95% chance of not getting sick.
Mm-hmm. Mm-hmm. How soon after the second dose are you considered protected?
About 2 weeks, I think, is what the data is saying, about 14 days or so after the second dose.
Mm-hmm. Is there any data from the success rates of the German company that co-partnered with Moderna to come up with it?
That would be with Pfizer. I think you're probably speaking to, and not Moderna. But I don't have any information, to pull from it at the moment.
Mm-hmm. I know for me, my immune system is not that great at all. Every time I get the flu vaccine, I get sick. Is it because they're injecting us with the actual latent or dead version of the virus? And with the COVID vaccine, which one do you suggest? Do the two different versions of the vaccine work differently?
Yeah, there are different flu vaccines.
Mm-hmm.
So, I think it's important to, and I don't know if I want to get into the weeds, but I think it's really important to sort of call out that oftentimes what people are experiencing after they get a vaccine is not that they're getting sick, is that their immune system is actually doing what it's supposed to do.
Yep.
Immune system is reacting to something being in your body, and the reaction actually in some ways says that your immune system is doing what it's supposed to do in response to what you were given the vaccine for, so that it's offering the degree of protection that you're seeking. And so I do know that, many people have horrible experiences with the flu vaccine, and, report all different kinds of symptoms as a result of taking the flu vaccine. But I would just offer that in most cases, what we're talking about here is your immune system is doing what it's supposed to do. But in terms of the Pfizer and the Moderna vaccine, the technology or the way that both of these vaccines work is nearly identical. So I don't necessarily have a sense of a preference. I think they both do the same thing and they operate in the same way. So it's really about, if you decide to take the vaccine, I think it's more about which one you might have availability to access, and not so much, which one should you take in that way. Because I know that not everyone will get, the way the shipments are happening and the way, people are sort of uptaking the vaccine. You may not necessarily have a choice. And then it's also, there's no data out there on mixing the vaccine. So I want to say that too. So, there's no data out there that says that people can go from Moderna for the first dose and Pfizer for the second, or, vice versa. So, yeah, I would just simply say that if you have the opportunity to get a vaccine, I would strongly consider it, irrespective of which one it is.
I agree. So that vaccine is getting your body fit to fight, is how I like to think of it. Fit to fight if you are exposed to the flu or to SARS-CoV-2 in the future. And I completely agree. The vaccine that will be available to you may be one or the other, or one that is subsequently granted EUA access or authorization, if you will. And so I would get whichever one is available. Moderna was available to me, and that is the one that I got. No questions asked. I was there with my sleeve up, ready to get my vaccine.
Awesome.
All right, next question. Is CIU a severe allergic reaction issue? Chronic idiopathic urticaria.
That sounds like a you question, Doctor.
Mm-hmm. And so CIU, so with CIU, my thought would be, if you have chronic idiopathic urticaria, I would let the doctor or the nurse, the team that is caring for you, know that you have that. And then I would monitor you for 30 minutes and we would have epi on standby. Because you may not have a reaction to the vaccine. Next question. Let's see. Can you talk about Tim Zook, the radiologist from Orange County who reportedly died from the vaccine?
I do not know this particular
I don't know the story.
And I guess in general, I don't have access to the health records of people who are getting vaccinated. Mm-hmm. So I don't know specifically, what their health status was. What I can say is that from the clinical trials that have been conducted so far, no one has died as a result of the vaccine. There have been people who have passed away from other causes, but no one has died as a result of the vaccine from the clinical trial data that I've seen. So,
well, one thing I want to mention about that is I want to encourage folks to dig deeper into some of these stories. For example, I had someone post on my page that there was a woman who received the vaccine and she fainted and died. I asked them to send me a link. I reviewed it. And this person has a history of fainting after they get an injection or have their blood drawn. And the person did not, in fact, die. So I want to just make sure that when we're getting information, that we are doing our due diligence to do research to make sure that what we're being fed is not misinformation, and that we are not then passing misinformation along. because in doing so, you're affecting the people around you and infecting, if you will, their minds on, the efficacy, the safety of a vaccine, and consideration for getting a vaccine. Because 9 times out of 10, if they follow you, if they are in your circle, they value your opinion, and so that space on your social media page or in your brain is really valuable space that you want to make sure is filled with evidence-based and factual information.
Can I also add that that because this comes up for Bell's palsy as well, and Bell's palsy is a health condition that we actually expect to see in communities and populations based on people's health status. There are many people who are sort of saying that, as you mentioned, because people got the vaccine, that they had these sort of impacts. And digging deeper for me, I want to share that it's, I think, really important for people to make the distinction between something that is the direct cause of something versus something being a part of the story. Because to me, there's a big difference. And in research and in medicine, we refer to that as correlation versus causation.
Mm-hmm.
So,
Mm-hmm.
if I decide to walk out of my house and go to the grocery store and get an ice cream pop, and on the way back from the ice cream pop, I trip over something and I fall, and my ice cream pop lands on the ground. Can I say that the store was responsible for me falling? Can I say that that the weather was responsible for me tripping? I think we really need to dig deep into understanding how the chain of events that happen in a situation may be a part of the story. It may be a part of the overarching sort of narrative about what happened with this person, but it may not be directly responsible for causing the situation that is being discussed.
I agree. So we're about 5 minutes to the end of this amazing conversation.
Went so quickly.
I know that hour went by so fast. So I want to give you some time, Dr. Wallace, to quickly share with us the resources that are available through the COVID-19 Trials Network.
Absolutely. We've put together a suite of materials that break down the science into accessible language, including the information about the messenger RNA vaccines, how people are able to participate in clinical trials. How did we get here so quickly with the development and the EUA authorization for 2 vaccines? And much of this material can be found via our website, www.preventcovid.org. You can also reach out to us on social media, Facebook and Instagram at Prevent COVID-19. And we also have a YouTube channel, which has a ton of videos on there in English, Spanish, and Portuguese. And we're also creating other languages that describe all sorts of topics and conversations, as well as there are some talks on there that we had with different health providers and different groups, different community advocates and leaders to talk about the trials, to talk about the research, and to talk about what's happening behind the curtains, because we do need to do a better job of taking the mystery and the mystique and illuminating, sort of what is actually happening in these clinical trials. And so the development of these materials is an effort to do that, to make sure that communities have accurate information about what's happening in the science, so that they can follow along as well. This is meant for everyone to be a part of this process, and certainly we want everyone to join us, whether that's as a participant in a clinical trial or as an advocate, or as just a community partner to say, hey, we want to support, we want to be involved, and we want to help you get the message out.
So that's preventcovid19.org, correct?
Preventcovid.org.
Oh, preventcovid.org. Okay,
Yep.
Great. We'll put that in the comments as well, preventcovid.org. All right. So one last thing that I wanted to mention before we wrap up, because I saw that there was a point about there being an inherent risk with getting a vaccine. And I just want to mention that there is an inherent, risk in many things that we do, right? But you have to also factor in what are the risks and benefits, and so that will be a decision that each of us has to make. I've already made my decision because I've gotten the vaccine, but that's the decision that we all have to make based on the available data that we have at hand, based on conversations with our provider or physician, with and deciding ourselves if this is for us. So
absolutely. And it's always a risk benefit conversation. I mean, we do risk benefit conversations every day. We often don't think about it in the same way. So it's important, this is, again, this is not to say that, there's no risk in the vaccines. We're still studying them. We will continue to follow and study them. And as we continue to learn more, we will share more information so that people can be informed consumers. But what we are saying is that from a risk benefit perspective, that the benefits of the vaccines seem to greatly outweigh the risk based on the information we have right now.
Awesome. Well, thank you so much for your time, Dr. Wallace. I think this has been amazing and extremely informative, and hopefully it's been helpful for those who tuned in tonight.
Thank you. I appreciate you and all that you do. I can't wait till this pandemic subsides so we can, go have a meal again. It's been a minute since I've seen you.
Right. It really has been a minute. I'm looking forward to getting back to being able to fellowship again.
Absolutely. Absolutely.
So I want to thank everyone for tuning in tonight. I also want to share that the Practical MD is going to be going through some updates. We're going to be having some new graphics, some new intros, and all new content coming soon. So you don't want to miss it. Follow me on YouTube, on Facebook, on Instagram at The Practical MD. So looking forward to connecting with everyone again. For those questions that were left in the comment section, I will go and review those questions and address them. Everyone have a great night and be well. Thank you.
Thank you.